This presentation is based on a module designed by the Harvard Medical School as a means to educate their students during this pandemic. This presentation is predominantly about the current known epidemiology for COVID-19. I'll begin with a few epidemiologic terms and conclude with some case scenarios. I hope you enjoy. If you've been reading about COVID-19, you've probably come across several epidemiologic terms. Here's a reminder of what they are and how they apply to COVID. The R0 is the basic reproduction number. Essentially, you can think of it as the contagiousness of COVID, or how many people will an infected person infect in an entirely susceptible population. For COVID, the estimates range from 2 to 4, but most models estimate 2.3. In contrast, the R0 of influenza is 1.2. The RE is the effective reproduction number. It is the R0 taking into account immunity. Currently, because there is no population immunity, everyone is susceptible. Thus, the R0 is equal to the RE. Mechanisms to reduce RE include vaccination, development of self-immunity by recovery after the infection, and social distancing. When the RE becomes less than 1, the outbreak will die. The incubation period is simply the period of time between when someone is exposed to the pathogen and the onset of symptoms. The latent period is the period of time between exposure and onset of infectiousness. This period can start prior to symptoms, and in the case of COVID-19, it does. This graph helps in demonstrating this point. For COVID-19, what we know is the latent period is shorter than the incubation period. This means that transmission is possible prior to symptoms. The incubation period from exposure to symptom onset ranges from 1 to 14 days, but on average is between 5 and 7. Transmission rates are unclear, but they're predicted to be long. The viral RNA has been detected in patients for an average of 20 days and up to 37 days. It should be noted that even if the viral RNA is detectable within patients, we do not yet know if this is live virus. So what does coronavirus look like when it does show symptoms? The most common symptoms include fever, dry cough, and fatigue. But the most important thing to keep in mind about COVID-19 is that 80% of folks who test positive have mild or no symptoms. Many have compared influenza to COVID-19, including myself. It is true that the symptomology are similar, but there are a couple key distinctions. Number 1, we have a vaccine for influenza, and this reduces the number of susceptible individuals in a population. Number 2, some have a degree of self-immunity to influenza due to previous contraction. Number 3, the basic reproduction time for influenza is only 1.2, meaning someone infected with influenza will spread it on average to 1.2 people. In contrast, the basic reproduction number for COVID-19 is 2.3. Lastly, the mortality for COVID-19 is much higher. Estimates range between 1 and 2%. In contrast, the mortality rate for influenza is only 0.3%. It should be noted that mortality rates increase exponentially with age. Social isolation of young, healthy, and asymptomatic patients are critical to disease control. This brings us to social distancing. Social distancing is a public health practice that aims to prevent sick people from coming in close contact with healthy people to reduce transmission. The goal of social distancing is to flatten the curve. Flattening the curve is a concept that by slowing the spread, there will be fewer cases at any one time. This is based on the idea that the healthcare system can only handle a limited number of sick people at any given time. By flattening the curve and reducing the number of patients that hospitals must care for, there will be less fatalities due to the ability to provide appropriate care. It must be noted that flattening the curve does not mean fewer people become infected. The same number of people will ultimately become infected, just over a longer period of time. The area under the curve is not reduced. I'm sure many of you have seen this image. Or this image. This is an excellent pictorial that shows if the case numbers rise above the dotted line, which will invariably occur without protective measures like social distancing, it will overwhelm the healthcare system. With social distancing, we can hopefully elongate the interval between transmissions to allow the healthcare system to catch up and cope. Here is another image describing this point. We have 738,000 total U.S. hospital beds. By spreading out infections over the course of 18 months rather than 6 months, we can provide appropriate care by having enough hospital beds and essential resources like ventilators. Insufficient resources will ultimately lead to a higher fatality rate. Social distancing saves lives. Currently, the CDC estimates that 2/3 of the U.S. population will be infected in the coming months. That's approximately 214 million infected, and 1.7 million will die. Remember, the area under the curve doesn't change, just the number of patients we must cope with at any given time. The question we are currently answering is, will those 214 million people become infected over the next 6 months or over the next 18? So to summarize, social distancing does not reduce the total number of infected persons. It reduces the impact on the healthcare system by slowing the rate of transmission and increasing the doubling time. Current estimates for doubling time are roughly 5 days. Effective social distancing can increase the doubling time to 20 days. In addition, it reduces the RE, the effective reproduction number. Remember this term? This is the estimate of contagiousness accounting for immunity or susceptibility. Because we don't have a vaccine and we have not yet built up self-immunity, this is our only means of reducing the RE. Social distancing buys the healthcare system time to get ready for this crisis. So as physicians, what should we be advocating? We should be encouraging friends, family members, and patients to cease all public gatherings of any size. The White House has recommended against gatherings of more than 10 people. The UK has limited gatherings of more than 2. Some cities have enacted shelter-in-place precautions, meaning individuals cannot leave home except to conduct essential activities related to health, work, food, and exercise. Lastly, it's important to understand and recognize that this is not a short-term problem. It is expected that social distancing will be needed for many months to be effective. The Imperial College recommends social distancing until a vaccine is made available. This could be 18 months. So how are we doing and where are we today? As of March 25th, 2020, there were 450,000 confirmed cases worldwide and 20,000 deaths. One must remember that current rates are grossly underestimated due to the incubation period. Remember, symptom onset is 5 to 7 days. In addition, 80% are essentially asymptomatic and there is limited testing. In fact, it is estimated that for every 1 case reported, there are at least 10 to 50 cases that we don't know about. With these estimates, that would mean 4 to 20 million worldwide are currently infected. And in the US, approximately 500,000 to 3 million. So how are we doing, and where are we today? I'll let you judge our curve. The navy blue line in the middle of the screen is the US. The purple line at the bottom of the screen is South Korea. I'll let you judge the curve. So let's go back in history and see if we can learn from our past. The 1918 influenza pandemic, or Spanish flu, also called the mother of all pandemics, infected 500 million people worldwide, or half the world's population. Keep in mind that some had pre-existing immunity from prior influenza exposure. This is not the case with COVID-19. Overall, there were 675,000 deaths in the United States, and more died from the Spanish flu than World War I. There were 3 waves: spring, fall, and winter. This is expected for COVID-19 as well. Finally, the R was 1.2 to 3. Remember, for the R naught for COVID-19 is 2.3. So how did the US react at that time? Here are 3 examples of cities and how they reacted differently. In Philadelphia during the second wave, Wilmer Cruzen, the Philadelphia health director, advised, "Stay warm, keep your feet dry, and loosen your bowels." He did not advise social distancing. Instead, he held a military parade to raise war bonds. 72 hours after the parade, all 31 of Philadelphia's hospitals were full, and by the end of the week, 2,600 were dead. In St. Louis, before their first case even appeared, their health commissioner, Dr. Max Starkloff, closed schools, movie theaters, pool halls, and banned public gatherings. When infections did surge, thousands were treated at home by volunteer nurses. Because of flattening the curve, the peak mortality rate in St. Louis was 1/8 that of Philadelphia's. And in San Francisco, William Stevens, the California governor, declared it the patriotic duty of every American citizen to wear a gauze face mask. If you were in public without a face mask or wearing it improperly, you were arrested and charged with disturbing the peace, then fined $5. In addition, they were well organized, closed schools, banned social gatherings, etc. San Francisco did well in the second wave, but citizens thought the face masks were what protected them, not the social distancing. So during the third wave, businesses fought back to stay open, and San Francisco didn't do so well. So let's fast forward back to present day. On January 20th, 2020, the US and South Korea both detected their first case of COVID-19. In response, the South Korean government developed testing kits with an efficient rollout through cooperation between the private biotechnology sector and currently, South Korea can test 22,000 per day. As you can see from this graph, South Korea is currently testing 20 times as many people per million as compared to the United States. They also have created unique testing strategies with automatic testing by a machine rather than a lab tech to reduce transmission. They have drive-through testing and telephone booth testing where swabs are collected while the patient is in a negative pressure telephone booth-sized room. Further, they are offering testing to all individuals who have been in contact with a confirmed case, even if asymptomatic. By identifying asymptomatic carriers, their fatality rate is actually 0.7% in comparison to the global average of 3.4%. The government is fielding the cost of testing in medical care regardless of immigration status, and those that are quarantined are provided food and other essentials. They have not implemented travel bans or had a lockdown like in China. Rather, South Korea has focused on social distancing. and the public has complied. So I ask you again, how are we doing here in the US? And where are we today? I'll let you judge our curve.